Hi everyone, this is Tim, your Block 1 lecture instructor, and today we're going to cover Chapter 30, which is Pain Management. And the learning outcomes for this chapter are going to be define pain, classify pain according to origin, cause, duration, and quality, describe the physiological changes that occur with pain, discuss two physiological mechanisms involved in pain modulation, discuss the effect of unresolved pain on each of the body systems, discuss non-pharmacological pain relief measures, describe pharmacological measures, including non-opioid analgesics, opioid analgesics, and adjuvant analgesics. You should be able to describe chemical and surgical pain relief measures, explain why pain should be the fifth vital sign, identify the steps involved in creating a pain management program for a client, explain how to use a patient-controlled analgesic system, which is also known as a pain pump or PCA pump, and you should be able to describe a method for evaluating a pain management program. So what is pain? To me, with my experience as a bedside nurse, pain is whatever the patient says it is. It doesn't matter if they're in excruciating pain and they're crying and they're moaning, they're in pain. It doesn't matter if they're actually laying in bed on the phone, talking to their friends and laughing, and you come in the room and they're like, oh my gosh, I'm in so much pain. Pain is what they say it is, and it's not for us to judge whether or not they do or don't have it. So according to the slide, pain is unpleasant sensory or emotional experience. It can have a destructive effect, can warn of potential injury, and is a multi-dimensional experience. So classification of pain. By origin, it could be superficial, which is skin or subcutaneous tissue. It could be visceral pain, which is deep internal pain, which usually involves the abdominal cavity, the cranium, or the thorax. It could be deep somatic pain, which involves ligaments, tendons, nerves, blood vessels, and bones. Or it could be radiating pain, which starts at the origin but extends to other locations. It could be referring pain, which occurs in an area that is distant from the original site. Phantom pain, which is pain that is perceived to originate from an area that has been surgically removed, such as your legs or arms. Or it could be psychogenic pain, which is pain that is believed to arise from the mind. So there's also classification of pain. By cause, there's nociceptive and there's also neuropathic. By quality and by duration, which is acute, chronic, and intractable. So with nociceptive pain, it's the most common type of pain, and the causes are usually thermal, chemical, or mechanical, and the two types of pain are usually visceral or somatic. There's neuropathic pain, which is injury to one or more nerves. Duration can be acute, which is 6 months or less, or chronic, which is 6 months or more. Intractable pain is usually chronic and highly resistant to pain relief. So for ClickerCheck, it is most important for the nurse to understand the various ways in which pain is classified, so that A, he can document the client's pain using accurate terms, B, so that he can be clear in his communication with the physician, C, so that he can develop an effective pain management plan, or D, so that he can educate the client thoroughly. And the answer is going to be C. Different modalities are used in the treatment and management of pain and are often based on how pain is classified, which is acute or chronic. So physiology of pain, there's transduction, there's transmission, pain perception, and pain modulation. With transduction, pain-sensitive nociceptors found on the skin are stimulated by injuries, surgery, or procedures. And with transmission, pain from peripheral nerves to the spinal cord. With pain perception, it's recognition and definition of pain. We also have pain threshold, which is the point at which the brain recognizes and defines pain. And we also have pain tolerance, which is the duration or intensity of pain that a person is willing to endure. So factors that influence pain, it could be past experience with pain, it could be emotions, developmental stages, sociocultural factors, communication skills, cognitive impairments, and other illnesses contributing to pain. So the body's reaction to pain, according to this, is 30-1, but I actually found these in your volume 1 book on page 732 to 733, and here it actually goes through all the systems and how it affects, how pain affects these different systems. I also found for common pain responses, for physical, usually blood pressure increases, heart rate increases, and respirations increase. For emotional side effects, usually you'll see moaning, crying, agitation, and guarding. And for physiological, I found anger, depression, anxiety, and irritability are the most common symptoms that you see in your patients. So when you're assessing pain, you're going to obtain a complete pain history, which is going to be the onset, location, aggravating factors, and alleviating factors. You're going to look for nonverbal signs of pain, which again is the elevated pulse, elevated blood pressure, crying and moaning, and grimacing. I mean, you're really going to be able to tell whether or not your patient's in pain. So for pain scales, we have the visual analog scale. We have the numeric rating scale, which is the top picture on this slide. For me, in working at the hospital, this is probably the most common scale that I use. You go in, talk to your patient, and you ask them on a scale of 1 to 10, 0 being no pain and 10 being the worst pain of your life, where is your pain now? And then they usually rate it based on that. There's also a simple descriptor scale, which is basically asking them whether or not their pain is mild, moderate, or severe, which I don't find to be very effective. But we also have the Wong-Baker-Faces pain rating scale, which is basically the second picture. So 0 is no hurt, and 5 is it hurts the worst. We also use this one. A lot of times we'll use it for kids or adults with that either don't speak English very well or have communication problems. So nursing diagnosis, we have acute pain and chronic pain. And the planning outcomes would be to prevent, reduce, and eliminate. So it's that simple. You have pain, I give you some pain medication, and it goes away. So interventions and implementations, each situation is unique. Listen to the patient's report of pain. Again, pain is what they say it is. Support the patient in maintaining an active role. Provide prescribed analgesics promptly. So if they're allowed to have Percocet every 4 hours as they need it, then give it to them. We're not the narcotic police. It's not our job to determine whether or not they're having pain or not, and it's not our job to actually determine whether or not they're having too much or not enough based on our own personal judgments. If they're allowed to have it, then you give it to them. For the lack of better terms, I would probably be safe to say that as long as they're breathing and they're alive and they're not bleeding or sedated or dead, then keep giving them the pain medication. Because one, you want to control it, and two, again, it is what they say it is, and it's also based on that scale. So regardless of how they're acting or how you perceive them, if they're on a scale of 1 to 10 and they are a 10, they're a 10. So you're going to also assess for response for analgesics. So you'll give the Percocet, you'll wait about a half hour, you'll go back in, you'll ask them how they're feeling and determine whether or not the actual Percocet is actually working. Alter treatment if it's not relieved. So if you give the Percocet and a half hour it doesn't work, then try something else. Provide interventions to manage potential side effects. Pain medication usually slows down the bowels, and most of your patients will become constipated. So provide interventions that will manage the side effects. So side effect would be constipation. You'll manage it by giving them some sort of stool softener on a daily basis. Reduce anxiety and fear by teaching about pain management and allowing the patient to be in control. Again, using the scale, the numeric rating scale, and giving them the opportunity to be part of their pain management helps them be in control. Consult with the healthcare team about complex pain issues. If your patient has chronic pain or if what you're doing is not working, then work with the physician. And at my hospital, we used to have a pain management team. So I'd call them up, tell them this is what they're getting, this is the type of pain they're having, these are the procedures they've had, and they kind of work with us to figure out what will actually work better. And then delegate appropriate pain management strategies. So again, consult a healthcare team. So ClickerCheck, the nurse is assessing the confused client and trying to determine the client's level of pain. Their nurse should be aware that confused clients don't feel as much pain due to their confusion. B, observe the client carefully for changes in behavior or vital signs. C, ask the client's family how much pain the client normally has. Or D, use only pain scales that feature numbers or faces the clients can point to. And the answer is going to be B. The nurse should observe the confused client for nonverbal cues to pain. So for pain management, non-pharmacological measures, it could be cutaneous stimulation based on the gate control theory. And they have TENS, which is going to be, TENS is a transcutaneous electrical nerve stimulation. And then there's PENS, which is the percutaneous electrical nerve stimulation. There's also acupuncture, acupressure, massage, the use of heat or cold packs, and contralateral stimulation. I have a friend who's a chiropractor, and I have had nurses that I work with who have gone to him, and between the acupuncture, acupressure, massage, and the adjustments that chiropractors do, they have found that they feel a world of difference. So it doesn't always have to be just pain medication that controls your pain. It could be other things that actually help. Let's see, there's also immobilization and rest. So if your leg hurts when you bend it, then don't bend it. I mean, and it sounds stupid, but that's as simple as that. Rest, again, if you actually, rest it, elevate it, apply your heat or apply your cold packs, a lot of times these will actually help a lot. Cognitive behavioral interventions, there's distraction. There's muscle relaxation, there's guided imagery, there's hypnosis, therapeutic touch, humor, and journaling. Whatever you can get their mind off of their pain that tends to eliminate some of that pain. When you're alert and oriented in a walkie-talkie, laying in a bed, staring at four walls, watching crappy TV, you have nothing better to do but think about nothing but your pain. So if you can do some of these things, a lot of times that their pain will not necessarily go away, but just become lessened. So pharmacological measures, there's non-opioid analgesics, which are NSAIDs. There's also Tylenol. Opioid analgesics includes IV meds, IM, transdermal, epidural forms, and then there's also your PCA pump. Basically, it's a pump that has, let's say it's either morphine, dilaudid, or fentanyl, which are IV pain medications. They'll put it in this machine, and basically your patient, if they feel that they need something for pain, they push a button and it goes directly into their IV. It does have parameters. They can only hit it so many times every 15 minutes, and they're only going to get a certain amount every 15 minutes. So usually they'll put them on a continuous pulse ox, and you also kind of watch your patient a little more closely just to make sure they're not getting too much of the pain medication. Adjuvant analgesics is basically putting Percocet and morphine together, or Dilaudid and Scalaxin. You're using two different types of pain medications together to make the pain go away, or at least make it better. There's also chemical pain relief measures, which is nerve blocks and epidural injections. They have radiofrequency ablation therapy. They have surgical interruptions. Some of these I've actually never heard of before, and I actually had to look them up in your book. And I think I found it on page... 744. So take a look at those, kind of be a little more familiar with them. And again, I can't say they don't ever exist or have never been done. I, in my career, have not actually seen these before. So ClickerCheck, Mr. Zenobia, chronic cancer pain has recently increased, and he asked the home health nurse what could be done in relationship to his long-acting morphine. Which of the following is an appropriate response by the nurse? If you take more morphine, it will not change your pain relief. I'll call the physician and ask for an increased dose. The amount you're taking now is all I can give you. I'm worried if we increase your dose that you'll stop breathing. And the answer is going to be B. There is no ceiling on the analgesic effect of opioid narcotics. Patients develop a tolerance to the effects, which often necessitates an increase in the dose. So for misconceptions regarding pain, this is found on table 30-1 at the bottom of 745. One of the statements that kind of stuck out at me was there is a significant danger of addiction to pain medications. You'll find that patients who are usually 75 years or older tend to not want to take their pain medication for fear of being addicted. This is not true, and I usually explain to them that taking a few Percocets every couple hours is not going, for a few days is not going to make them addicted. I find in my own personal experience that patients who are going to be addicted, one, have either addictive personalities, or they're going to be on pain medication for a very long time, and then it's not necessarily addiction, it's more of a buildup of tolerance of the medication. They need more of it in order to control their pain. Another thing that they didn't mention in this box, which I thought was kind of interesting, is that patients will wait for pain medications. Assess your patients often and give them what they need as often as they can have it. If you stay on top of the pain medications, it or stay on top of the pain, it makes them feel better and they will recuperate faster. I find that if you can have Percocet, every 4 hours, I kind of roughly around the 4 hour mark ask them, how is your pain? Is it creeping up? If it's time for pain medications and you give it to them, then you're staying ahead of the pain as opposed to waiting until it's, worn off and their pain is increased and now you're trying to play catch up. Another thing that they also didn't mention that I thought was interesting is that explain to your patient about pain. If they've had, let's say, a surgical incision anywhere on their body, you can take away pain, but you can't take away incisional pain. So they're going to be at some level on that numeric scale. They may be at a 2 or 3 or a 4, but you'll never get them at a 0 unless you knock them out. So if you explain that to your patients and they understand that they're going to be at a 1 or 2 or 3 or a 4, then they're not constantly asking for something for pain because you're just chasing it. You'll never reach that 0. So I think that's kind of important to explain to your patients too. So special nursing considerations, managing pain in the elderly. I find that not only do they not want their pain meds because they feel they're being addicted to it, but you also have to watch how much you actually give them. Start off low and work your way up. If you give them a really, really small dose and it doesn't work, you can give them more. If you give them too much, you can't give them less. So if you give them too much, especially with elderly patients that are, especially the 90-year-old grandmas, you know, they'll stop breathing. So, like I said, start off slow and give low doses and work your way up. Manage pain in clients with addictions. Again, people who come in and you're giving them pain medication and giving it to them over and over and over, patients with addictions have tolerance to pain meds. So keep that in mind and don't just classify them as a drug-seeking patient. You have to realize that they're just addicted to pain meds and you're going to have to try to do something different. And then there's also the use of placebos, but that doesn't really happen in the hospital. So teaching the patient and family, monitor for excessive sedation, monitor for inadequate pain relief, and then on 747, let's see here what that one says. I think for 747, it's more of documentation and evaluation. Again, given pain meds, document it, and evaluate. And here we go, documentation. The expected outcome, the patient's pain level at the present time, the patient's response to interventions, any adverse reactions, and plan interventions to improve pain relief. So again, give them 2 Percocet. The expected outcome is to be pain-free. You're going to assess them 20 minutes later, and then you're going to actually chart whether or not it worked and whether or not they had any effects. Some people are allergic. They sometimes get hives. Percocet usually makes most people nauseous, so try to give it give it to somebody who's actually had something to eat. If they can't eat a lot, give them some milk or crackers or something to coat their stomach. And again, documentation is the key. So evaluation, critical to pain management program. Are the pain scores improving? Is the patient's behavior, mobility, range of motion, move, effect, consistent with pain relief? What is the quality of the patient's life according to the patient's standards? So if they're in chronic pain and they're always living at a 5 and they're at a 5, then it's working. So again, ask them what their pain is on a scale of 1 to 10. Ask them where they would like to be. I've had patients that would like to be at a 7, and that's good enough for them. And that still allows them to be in a good mood, still allows them to walk, range of motion. They're still able to function because sometimes that's the range that they live in. So for critical thinking, which group of patients are most at risk for inadequate pain management? What can you do to assist each group? And how do past pain experiences affect present pain experience? This is the end of the PowerPoint, and bring your questions to class, and we'll clear some things up. Thank you very much.